Good morning, and thank you. One disclosure there from Dr. Dimick. Laparoscopic gastric band was approved by the FDA in 2001 and became quite popular and widely adopted. As many as 80,000 devices were placed annually in the United States. After it was widely adopted, it became clear that there were also unique complications associated with the device, including erosion in the stomach and slippage of the band, causing obstruction. Multiple reports exist in the literature describing rates of reoperation after device placement. Interestingly, these rates vary anywhere from 4 to 40% in these case series and studies. And so part of our initial work in trying to understand the band and how to evaluate it was first trying to dig at why is there so much variation in these reports. So some of our previous work, we looked at variation in reoperation rates for the gastric band across the United States and Medicare beneficiaries based on where they underwent their initial operation. And we find that when you divide hospital referral regions into quartiles, there's almost threefold variation. So it's actually very plausible that some of these smaller studies, just based on where the patients were in their sample and where their operation was performed, actually mirrors a lot of the variation seen in the published literature. At the same time we were doing this, we also noted overall in Medicare beneficiaries, 18% of them required at least one reoperation, and on average, patients underwent 3.5 reoperations. So if you're looking at those numbers like we were, you might be scratching your head and start to realize if 1 in 5 patients are getting a reoperation and they're undergoing 3 to 4 reoperations, the reoperations may start to total the number of initial operations you're doing to place the device. And as someone who's interested in healthcare delivery and policy, the next immediate question was, how much are reoperations costing payers? So to look at that further, we reviewed Medicare claims data from 2006 to 2013 that included a total of about 26,000 patients. This was 7 years of the most recent data available from Medicare, and also importantly at a time when the lap band had already evolved to its second generation that was thought to be the safer version of the band. We use CPT codes, procedural codes that are used for billing to identify specific reoperations that included removal and revision replacement of the port, removal and revision replacement of the band, and then conversions to a different bariatric procedure, including a bypass or sleeve gastrectomy. To identify payments, we created 30-day total episode payments for each of the reoperations. That included the payments for the physician services, payments to the hospital for the index admission, post-acute services, and then the readmission that followed if it was within 30 days. Here's a quick table that shows you the difference in index operations and reoperations. Across every payment category, reoperations were more expensive. Seen here for index hospitalizations, about $12,000 versus $10,000. Physician services and readmissions, you see the same thing. Post-care discharge was more expensive in reoperation patients, in part because it occurred more frequently. And then finally, total episode on average was roughly $19,000 for a reoperation and $12,000 compared to the index operation. So what happens when you start to put all that data together? You sort of see here nicely sort of the rise and fall of the gastric band. The dark blue bars represent payments for index operations by year, and the light blue bars represent reoperations. And you can sort of start to appreciate that maybe around 2008 or 2009, there's a tipping point in Medicare data where you see that the reoperations actually costing just as much to payers as it is to place the device. To show this another way, of the $470 million spent by Medicare on gastric band procedures, 44% of that payments was for reoperations to either remove the device, revise it, or to convert patients to a different procedure. Of course, this is Medicare data, and our initial reaction was, well, you know, Medicare data, a lot of these patients get bariatric procedures because they're on disabilities. Is this really generalizable? Could you really say this is truly what's happening with this device across the country? So I threw this slide in because I realized a lot of people were out late last night, so to remind myself to drive home the key message, here's the focused version, roughly half the payments for reoperations. So we repeated the same study in the national inpatient sample. This is a 20% sample in the United States that includes Medicare patients, but also private insurers as well, to try to get a sense if our findings in Medicare data were really just a patient selection issue of maybe sicker patients who are more likely to get reoperations, or if this was really generalizable This time we included nearly 250,000 patients undergoing bariatric procedures. In Medicaid patients, we found that reoperations were roughly 40% of the payments of the $118 million spent. In private insurers, of the $1.5 billion spent on the gastric band, roughly $700 million was spent on reoperations, or about 40%. And when you aggregate all these payers together from the estimated weighted samples of the $2.3 billion spent on the gastric band, just over 40% of it was spent on reoperations. So it's an interesting question. Every time I've talked about the gastric band, the first question is always, isn't that kind of in the rearview mirror? Who's really putting the gastric band in that often anyway? So I want to present the data to you again in a slightly different way, and this time maybe have the hat of the FDA and warning signs in mind. And you can see here the annual number of gastric band procedures with the device being placed. You can clearly appreciate around 2008 it peaked and then slowly downtrended. And here are the reoperations shown in the lighter line. Interestingly, in 2011, this was at the time when the FDA reevaluated the device to decide if indications should be modified. And based on the small clinical trials that had 1 to 200 patients, they actually decided to expand indications of the device. But clearly, if they were looking at administrative claims data, they would have realized that we've actually hit a tipping point where reoperations for the device were more common than actually placing it. It's a little more pronounced when you look at payment data. So this is payment data in the national inpatient sample by year. The top bar being payments to place the device, and the bottom line being payments for reoperations. As early as 2009, so this is just after the band had peaked in popularity, already 30% of the payments that insurers were using for gastric band devices operations were for reoperations. Again, in 2011, that same year when the device was being reevaluated by payers, by FDA, more than 50% of the payments were for reoperations. And this is pretty remarkable. In 2014, the most recent data we have in the inpatient sample, 90% of the payments that we're spending on the gastric band device are for reoperations, and it's been really underscored at this meeting with an entire session, I believe it was yesterday or 2 days ago, on how to remove the device. This study should be interpreted in the context of many limitations. Our primary analysis was done in Medicare data that may not be generalizable, but based on our secondary analysis in the national inpatient sample, we feel pretty comfortable that it is a real finding and representative of a lot of patients. Second, there are a number of unmeasured outcomes that we couldn't address in claims data that are particularly pertinent to bariatric procedures, including weight loss, resolution of comorbidities. We see those as in addition to the safety concerns and payment concerns, and not instead of. And then finally, the reason for reoperation. It's a little difficult to tease out how many of these reoperations were for acute scenarios where the band eroded and it was an emergency XLAP, or if these were issues where the patient had a preference or the provider had a preference to have the band removed more electively. So moving ahead, I would love to, SAGE is one of my favorite meetings because we talk so much about innovation, technology, and new devices. And I think the gastric band provides a little bit of a cautionary tale about monitoring medical devices and are we doing enough, and thinking if there isn't a way for claims data to be used prospectively and proactively as we start to adopt new devices to try to identify warning signs of when a device doesn't seem to be doing quite what we hoped it would. I'd like to thank the Robert Wood Johnson Foundation and the Department of Veteran Affairs for funding my role as a clinical scholar, and the group shown here at Michigan, including my mentor, Dr. Dimmick, for helping me develop this work. I have to throw in a Go Blue since we're in March Madness, even though we lost. And with that, I'll take some questions. Thank you.